What we'll do here is just take an overview of the evidence base for CTOs, and we'll also cover some overarching concepts of how we treat it. So the learning objectives will be understanding the prevalence, the rationale for which patients should undergo PCI for a CTO, what are our current outcomes but with the best tools and techniques that we have, and we'll talk about basic antegrade, retrograde techniques and review some of the devices that are available and the evidence base for using them. So let's go back and look at some historical data. This is single center data from the Cleveland Clinic looking at how often CTOs are present when patients come to the cath lab. So in almost 6,500 patients, using a cutoff value of 70% stenosis, what they showed was that surprisingly as many as 25% of our angiograms have a CTO present. This is any CTO, tiny vessel, large vessel. It might be more than you might expect, but consistently studies have shown that around 15 to 25% of our angiograms will have a CTO, so that's a good number to carry. The other point about this study was that CTOs drive our treatment recommendations. So CABG, 40% got CABG and 49% got medical treatment, but only 11% got PCI. Okay, so the presence of a CTI is a deterrent presence of a CTO is a deterrent for PCI. The other thing is, just kind of something to keep as a knowledge item, is the presence of peripheral vascular disease is an important independent predictor of a CTO when you do an angiogram. So let me bring you to current practice. This is data from the Cath PCI registry. How often are we performing PCI for a CTO? So the average number is 4.3% when you take all the cath labs across the country. And it's very, very skewed. So many cath labs are only doing 0 to 2% of their PCI volumes for CTO, and then there's a small number doing somewhere around 5 to 10% of their case volume. So very high volume centers, but there's a handful of those. But the number to remember is around 4% of all PCI is currently for CTO. Let's look at it another way. So if you have a CTO, how often are we offering PCI? And that number is around 11 to 12%. Very much like what I just showed you from the Cleveland Clinic. 11% was in their data 2 decades ago. So even though we are improving in our techniques and understanding, the volume of PCI is low, and the rates at which we offer it for any CTO are low in terms of PCI. What about success rates with all the new techniques that we have? This is again Cath PCI registry data, looking at relatively higher volume centers, so centers that had at least 30 CTOs per year, and the average rate of success is 60% in this bell curve distribution. Okay, so we hear 80 to 90%, but around the country the success rate is around 60%. This is looking at more at operator level success rate, so we have mean annual volumes for CTO, and remember the majority of people are doing somewhere between 0 to 10, and there is an inflection point around 10 cases per year. Once you get over that, that's when your success rates start to increase, and you have to be really doing around 30 to 50 cases a year to really do those sort of 70 to 80% success rates. Okay, so you do really need a dedicated person doing this to get the high success. What about complication rates? A few numbers to remember. This is data from a meta-analysis that showed that the MACE rates are around 3%. And perforation, which is dreaded complication, is also around 3%. This is older data. What about currently? This is data from the Open CTO registry, just published last year. 1,000 patients from very, very experienced operators. MACE rate higher than what you might expect, 7%. Okay, largely driven by clinical perforation rates, 4.8%. Might be higher than you think, but of course these are experienced operators doing the most complex cases. This data was derived from centers that were in NCDR, and so they were very, very careful to make sure that all CTOs were submitted into the registry. There was no selection bias. Okay, so this is very complete data. This is data from the Progress CTO registry, a competing registry which shows something similar, maybe not as high a rate, but they looked at according to the technique used, antegrade wire escalation, antegrade dissection, or retrograde approach, okay, and showed that, as you might expect, actually the MACE rates depend on your technique. So they may be as low as 1% if you went antegrade, and as high as 6% if you went retrograde. Same is true for perforation rates. But again, the MACE rates are around 3 to 4%, similar to open CTO, and perforation rates are probably around 4 to 5% when you do the most complex cases, even with very experienced operators. So, based off that and some data I'll share with you in a moment, the current guidelines at best are a Class 2A recommendation for doing PCI for a CTO. There is no Class 1 recommendation. And it is very guarded. It says that it's suitable for appropriate clinical indications, which is highly subjective, and when the anatomy is suitable, which is subjective, and with appropriate expertise. Okay, so you could take it for what it's worth. What about the AUC? All right, so the 2012 AUC did include CTOs, and actually that was a bone of contention for a lot of the CTO operators because they said, well, no other lesion subset is in here. There's no long lesions, there's no bifurcations, there's no left main. So why pick on CTO as an AUC criteria? But nevertheless, at that point, they were only recommending PCI for class 3, 4 symptoms or a high-risk stress test in the presence of maximal therapy. So a very, very small population patients would meet AUC criteria. Now, we don't have to worry about that anymore because the 2017 AUC criteria have removed that from the tables. So CTO is no longer an AUC criteria. So let's go through the rationale for doing PCI in these patients, and you could think of that in terms of angina relief, improving outcomes following an acute coronary syndrome. That could be a rationale. Improving survival, of course, that'd be great. Improving LV function, or reducing the need for CABG. You could have somebody with single vessel disease. If you could open it up, they wouldn't need CABG, or even multi-vessel disease. So I think those are very important rationales. Now, the ones for which there is very clear data are 2 of these 5. For angina relief, there is overwhelming evidence that obviously a successful PCI works. And for reducing the need for CABG, again, very intuitive. But for all these other indications, I'll show you the data is pretty soft. So let's look at the angina relief data. This is a meta-analysis, 9 observational study, and shows that if you have a successful PCI for a CTO, you reduce the odds ratio of having angina and follow-up. Makes sense. So it is effective and highly effective. We don't have randomized data of this nature, but this is all observational. What about improving the tolerance of an ACS? Can we improve outcomes in patients who've recently presented and we find that there is a non-culprit CTO? This is the prevalence of CTOs in STEMI patients. If you don't have diabetes, it's around 12%, but as many as 20% or 21% of diabetics, when they present with a STEMI, actually have a CTO. Okay, so can we alter their outcomes? And their outcomes are pretty poor. If you don't have a CTO when you have a STEMI, your outcome is around 10% mortality at 1 year, but if you have a CTO, it's as high as 30%, which is much higher than you might expect. So it would be desirable to improve their outcome if you could. This is data from a randomized. What I just showed you was observational data. This is from Horizons AMI, a randomized trial. So remember, randomized trials patients are lower risk patients. But even there, if you had 2-vessel disease and a CTO, your mortality rate was much higher. If you had 3-vessel disease, your mortality rate was around 20% at 3 years. So CTOs, as you might expect, their presence as a non-culprit after a STEMI predict outcome. So this is the only trial that's attempted to answer this question. Can we alter the outcomes if we deal with the non-culprit CTO after we've fixed the culprit lesion? And these patients were treated in a matter of weeks after their presentation. They underwent a second procedure to treat the CTO, and the primary endpoint was not a clinical one. This was LV function, was a surrogate endpoint. And what you see is that there's no difference in ejection fraction or diastolic volumes in patients who are randomized to CTO PCI of the non-culprit vessel in follow-up. So as best as we can say, currently, treating a non-culprit CTO after a STEMI presentation doesn't seem to improve LV function, and they followed this up with a non-primary endpoint. So the primary endpoint was the ejection fraction, but during their clinical follow-up for 5 years showed that there was no difference in outcomes. And that's surprising because, as I just showed you, their mortality rates do seem to be higher, but it may be that they're not dying from their CTO necessarily. It's the cumulative atherosclerotic burden or whatever else they have as diseases that's determining their outcome. Can we improve survival? And There's a lot of observational data to support that survival is better. These are many observational studies comparing PCI success with PCI failure, and always all of them have shown that if you have a successful PCI, the survival is better than if you have a patient whom you've failed opening it up. Now, that's not really a randomized trial answering the question we want to know, but this is the best data we have. And so there are proponents of saying, well, we can improve outcomes. But likely, this could be driven by the fact that we are more successful in opening CTOs in less disease, less complex coronary anatomy. So that might be why these patients are doing better, not because we've opened the CTO. That said, one of the largest analyses from Mid-America Heart looked at thousands of patients and found that although the circumflex and right coronary artery don't seem to derive this benefit by opening, the LAD is the one vessel that if you do open up in observational data sets seems to have better survival. So this is the best observational data. Do we have randomized trials? To date, there have only been 2 randomized trials looking at outcomes based on CTO. Now, as you know, that's pretty much a remarkable thing that these trials have even been done because it's so hard to enroll patients. They have not been published. They have been presented at conferences. The first is a non-US trial, a decision CTO, done in Korea and other countries around there. It was a multi-center international trial. And the patients were randomized to the medical therapy, so almost like a courage trial for CTOs. And the success rate was pretty good, 91%. JCTO score was around 2, so these were at least moderately complex lesions. But there was a crossover from medical therapy to PCI, just like in courage trial. You know, every time you randomize patients to medical therapy, there is a crossover to revascularization, so that might have been one of the limitations. All that said, there was no difference in the 2 arms. So opening CTOs didn't seem to improve clinical outcomes, follow up to 5 years. So that was disappointing. And you could argue that there were many limitations, but nevertheless, this is the best trial of 834 patients that we have. The other trial to be aware of is the EuroCTO, as the name suggests, done in Europe. And again, this study took multivessel patients and first treated any non-CTO, got that out of the way, and then randomized the patients to medical therapy versus PCI for the CTO. Okay, and these were radialists, many of them. Success rate was very high at 86%. And the primary endpoint was not clinical here. They used the Seattle Angina Score to look at quality of life and symptom control. And the interesting thing is, as it often is the case when you compare medical therapy to PCI, the medical therapy arm also improves. Okay, so you see this improvement even in the medical therapy arm in terms of the various aspects of the questionnaire that patients improve, but the improvement was greater in the revascularization arm. So it provides tantalizing supportive evidence, again, that symptomatic improvement is there, quality of life improves, but do we improve hard endpoints, myocardial infarction, mortality? No, this study did not answer that question. So the best randomized data that we have does not support that CTO PCI improves our clinical endpoints, but a lot of observational data there to support that it does. Can we improve left ventricular function? And again, this is an MRI study where they looked at the thickness of gadolinium hyperenhancement in the target myocardium. So as long as you didn't have much hyperenhancement, you did get a lot of improvement. In other words, if you had viability, you improved, and the improvement continued out to up to 3 years. So the first follow-up point was at 5 months, and there was already improvement in LV function, and out to 5 years it continued to improve. But once you get to any more than 25% hyperenhancement of that wall, you don't see much improvement. So viability is important. So if the patient has sort of atypical symptoms or has a heart failure presentation, then viability testing is important because that could determine whether you get improvement in ejection fraction. Certainly in our experience, we have had patients who've had remarkable improvements in their ejection fraction from as low as 20-30% up to 40-50%. What about reducing the need for CABG? This is just a meta-analysis that clearly shows that successful PCI reduces the need for CABG. All right, so that's kind of our evidence base. Let's move on to some of the technical aspects in the remainder of the presentation. So as we think about preparing for a case, we need to think about appropriateness for the clinical indication. Clearly, you should, for the boards, you need refractory angina, not controlled by medical therapy, or a very high-risk stress test, or viable myocardium, just like I just showed you. Okay, you have to have one of those clear indications. And then you need to think about the anatomy. Is it suitable? Remember, it's a Class 2A recommendation, and it requires that the anatomy is suitable. So you need to think about three aspects of the CTO: the proximal cap, the landing zone, which is the distal vessel beyond the distal cap, and the presence of collaterals. And study them well, and it's reasonable to study these for several minutes before you plan your case. And the three broad areas of competencies are the antegrade wire escalation technique, which is basically an iteration of what we do every day with our non-CTO PCI, antegrade dissection reentry, and retrograde techniques. And really, you have to have the full package, and it's a learning curve for each, and you can start with one or two techniques and build up as you go along. But the approach we take now is that really we go in with all these three approaches available to us when we do a CTO, rather than as we used to do in the past, where we try the antegrade, and if we fail, bring them another day and do a retrograde procedure. It is important to be familiar with at least one of the anatomical scoring systems. The JCTO score is the most widely used, both in research studies and clinically whenever we do want to score them. And the score has 5 criteria. The proximal cap, is it ambiguous or not? The amount of calcium, the amount of tortuosity in the lesion, the occlusion length, and 20 millimeters is the number to remember, or whether this is a retry. So the score could go from 0 to 5. And so a 0 is easy, and anything of 3 or above is a very difficult CTO. So again, something that the boards might put there as a JCTO score and want you to know how complex that lesion is. So in terms of setting up for good success, spend 10-20 minutes thinking about the anatomy, looking carefully for the collaterals, the cap, the distal vessel. Bilateral injections are helpful, so if they've not been done at the time of the diagnostic angiogram, very important to do it before starting your procedure, because you will see collaterals that you never saw before. Calculate the score. I think it's very helpful. Look at the microchannels. We'll come to equipment and crossing strategies in a moment. So let's start with the antegrade approach. High support catheters are needed, and we use 45 centimeter sheets routinely for both sides, antegrade and retrograde. You can choose your catheter of choice, but use high support catheters whenever possible. We've gone away from using over-the-wire balloons, of course. We have excellent microcatheters, and you could pick any one you like. They're all they have their pros and cons, but the majority of them are as good as the other for the vast majority of cases. And then we have these sort of dedicated catheters that are directional, the venture catheter, supercross, and so on, that are very useful in specific situations. So for example, the venture catheter, it is a large catheter by any stretch of the imagination, and so it can only really be used in large caliber areas. So that would be, for example, if you're doing a circumflex and you want, and it's very angulated, so you can really get a good entry into the circumflex using this catheter, which can bend about 90 degrees. The supercross is very similar, but it is one angle only. You can't adjust it. Another area that these catheters are very useful are if you're going down vein grafts and there is a more than 90-degree bend to come back retrograde. It's a pretty useful catheter for that purpose. But on the whole, we don't find a great use for them. So as you think about the various antegrade techniques, antegrade wire escalation is preferred if you can do it. The usual way for starting with them is use the field or XTA to look for microchannels. Remember, the microchannels may be present even when you don't see them, so it's worth a try. But if you're really, really sure that this is a rock-hard lesion, calcified, then you can go to the next step, which is using a medium stiffness wire, and you can have your wire of choice. The Gaia 2nd is a very good wire. It's highly steerable, and so I think it's replaced much of the previous wires that we used to use, like the Miracle wires. And if you don't succeed with that, or you're really convinced that this is rock hard and it's a short CTO and you know where you're pointing, then you can use the Confianza wire and aim where you want to go. But we moved away from just going straight to the confianza because it goes the path of least resistance. And if you don't know where you're pointing, you're going to end up in places you didn't want to be. So it is certainly worth using, but I wouldn't go straight to that. Other techniques that we are not using very much are techniques like the parallel wire technique, seesaw technique, largely because those have been replaced by dissection techniques. So I think if you don't manage to cross with the initial antegrade wire escalation, then I think you should think of an alternative technique such as dissection. This is just a pathological specimen showing how microchannels are present frequently within a CTO. They could be peripheral, they could be central, but the ones to avoid are these adventitial ones. These are the ones that are going to get you into trouble. And that's just by studying the angiogram carefully, and I think you can stay out of them, but not always. So I think you just have to watch out. Understanding the concept of penetration power is important both clinically and for testing purposes. So the BMW or any workhorse wire is down here, which has penetration power measured in grams per square millimeter of around 20, let's say. And then you have the confianza wire at the other end, which is 10-fold greater penetration power. Okay, just a concept to carry, especially as new wires come on. You need to be able to understand where you want to put them in that spectrum of stiffness. Other techniques that are not used a lot in the US are IVUS-based guidance to enter a antegrade cap, used a lot in Japan. In fact, they have it in their algorithm, but the US algorithm doesn't have this technique. But I think it's one that it does work, but you need large caliber main branch, large caliber, or reasonable caliber side branch in which you can wire and put your IVUS right next to where you think the carina is, and then image the cap. And this is just an example of a blunt occlusion. It's an ambiguous cap. You can place the IVUS catheter down the branch here, and what you see is the IVUS catheter in the side branch, but you clearly can see a plugged up target vessel, and you can attempt to wire it. And once you can see the wire on the IVUS, you're in, and then you don't have to do any more IVUS imaging because you're in the cap, and you can then continue wiring as you would normally. So it is a useful adjunct technique. What about subintimal entry? Well, a lot of the time it's unintentional, right? You're planning to go true to true lumen, but you end up subintimal. It used to be, we were taught that that was an end game and that you have to come back with a parallel wire technique. Nowadays we continue wiring as long as we know that we are in the vessel itself and have not exited. Or you could just start up front with a dissection technique, and that can be done with polymer coated wires such as Pilot 200. And this is really something that the US experts have really propagated because they like the idea of covering the CTO, particularly long CTOs, with this dissection and then re-enter distally. And it certainly saves time, but it has a steep learning curve. And again, like all the techniques that we have, doesn't always lead to success, but it's worth being familiar with it. The other way of doing an antegrade dissection is using a crossboss. So crossboss is a dedicated tool for doing subintimal dissection in a controlled manner, and we'll come back to that in a moment. So this is a hydrophilic coated tip, 3 French, and it's spun manually at high speeds as fast as you can go, and the idea is that it goes down the path of least resistance. And sometimes it works beautifully and other times it doesn't. It has a tendency to go down side branches. So it's best not used if you have a lot of tiny branches at the proximal cap because you'll just end up down them. But if you don't, it's a useful adjunct to have. Once you've done your dissection, you have to re-enter. Now, it may be that you're lucky enough and you enter by chance, and that can happen, but many a times you need to do a sort of a thoughtful way of re-entering, and to be able to do that, you really need a healthy distal vessel. If you have a very diseased vessel, you're not going to be able to enter with any technique. And this Stingray balloon is a dedicated balloon. It's a flat 2.5 millimeter wide balloon, and the way it's done is that you place it in your entry target zone. Usually it's used in the right. When you get to the distal segment, you place it flat, so you move your camera till you can see the profile, and then it has 2 exit ports, one up here, the other one is on the opposite wall, and they're offset a little bit. Very difficult to see. You have to mag up, you have to cone in to be able to see and make sure that you have the right profile, and then you place your wire through it and hope that you can re-enter. There is a dedicated Stingray wire, but most of the time we don't use it. It has a hook at the end. We tend to use other wires to do the re-entry. There are 2 trials using the crossbars, and let me walk you through them. The first one that brought this tool to the market is the Fast CTO. It was a single-arm study, essentially 10 minutes of antegrade wiring, and if you failed, the patients were entered into the crossbars arm, and the crossbars was successful 77% of the time, with low MACE rates 4.8%, and so the device was brought to the market on the basis of this study. There has been just 1 randomized trial published this year. This is a crossbars first trial, so the patients were now randomized to either antegrade wiring or using the crossbars as your upfront technique. A lot of patients screened, almost 1,000 patients. Only 246 were entered into the trial. Moderately complex lesions, so JCTO score of 2. Very experienced operators doing the trial. And primary endpoint was time to crossing. And there was no difference. So whether you used your wire or your crossbars, the crossing time was the same. There was no difference in procedural success rate, MACE rate. So essentially, it's non-inferior to wiring, but it's not superior. Okay. It's certainly a good adjunctive tool to have. What about, and this is where our heart sinks, you cross, you spend 80 minutes trying to cross the lesion, and you think you're almost home now, and you can't cross with anything. And I think it's important to have a stepwise approach to this, and this is very testable, I think. So you have initial steps, which is using smaller balloons. We don't have the smallest balloons that are available in the US, but certainly 1.2 millimeter balloon. There's a threader, which is a dedicated stiffer shaft balloon that you could try, but in our experience, I think that has not been particularly helpful in this situation. You could try to rupture a balloon to modify the cap. Pretty cheap and a way of trying that, and occasionally works. Use a microcatheter if you are not, but most of the time we're going in with a microcatheter, and there's a whole line of them. The Corsair is pretty good sometimes. The recently available Turnpike, and I'll show you an example of that, is very good in certain situations. And you can optimize your support. You just bring a guide liner in and then see if you can cross with the balloon. Okay, so these are your initial steps. Second line steps are lasering, and certainly we've done that with the good success. So if nothing crosses, you bring the laser, you laser the proximal cap, and then you're able to cross. And the final thing is just give up and go subintimal, which is the last thing you want to do because you spend almost 2 hours getting to this point, and now you've got to start a subintimal entry. But it's been described, and it can work because you've got your first wire as your landmark, and so you just have to follow that with a subintimal entry. But easier said than done, but it can be done. Here's an example of the original Tornus catheter, which we don't use. It's a screw-like device that you can screw through if nothing else is crossing, and the Turnpike Gold has largely replaced that. So this has this golden screw at the tip, and it's got us out of trouble occasionally. So it's lower profile than the Tornus, much easier to use, and it screws nicely, but doesn't always work. It's a kind of a 50-50 thing. You've used the guide liner to increase support. We just talked about that. There is now the trap liner. The trap liner combines the guide liner with a trapper, which are devices that we need almost always in CTO cases. So it's a nice alternative to the standard guide liner. Okay, so you cross, but you now can't dilate, and that can happen in heavily calcified fibrotic CTOs. So you again need to have a systematic approach to that. And again, high pressure inflations, buddy wire, angiosculpt, that doesn't work. So go quickly to lasering or rotational atherectomy before proceeding. So retrograde CTO reported many, many years ago, 1990, but it's really been taken up more recently. It has dedicated equipment, the Corsair, which you need to be familiar with, that has this 10 elliptical stainless steel wires that are wrapped around, which allow torque transmission through the tortuous septals. There are dedicated wires, Fielder FC and Scion wire, which is the ones that you should use. They are designed specifically for collateral crossing. Recently, the Suo wire has been launched in the US. This is for epicardial collaterals. It has just 0.3 grams tip stiffness, very, very soft at the tip and very trackable. And then the other wires you need to be familiar with are the RG3, R350. These are the wires that when everything is done, you've crossed the septal, you're retrograde, you need a long wire to complete your procedure, you switch out to this wire. Here's just an example of that. This is an example like an RG3 that's been passed through the LAD out through the right, through the antegrade guide. And in terms of retrograde techniques, there are many described, but the one that's mostly used is the reverse cart. So in the reverse cart, what you do is you get your retrograde wire all the way back as far as you can to the proximal cap. Usually you just can't get through the last few millimeters. What you do is you bring an antegrade balloon in and do a balloon inflation, break up the plaque, and then the retrograde wire, in theory, should fly through into the antegrade guide. Here's just an example of a retrograde approach with the reverse cart. So you've got your wire all the way through the septals into the right coronary artery, but it's not crossing any further. It's subintimal here. What you do is you bring the antegrade wire, you do a balloon inflation, and hopefully then the retrograde wire enters your antegrade guide. So what is the success rate with this technique? In the Japanese hands, it's 96%, but in Europe, it's 64%. And that's pretty much how it is in the US, too, with the retrograde approach. It may be just the kind of patients we select, or it may be a true technical expertise issue. There are complications. Be aware of using the retrograde technique, of which obviously dissection, perforation, but a septal hematoma is a very bad thing to happen. This is just an example of it. This is echo showing the hematoma in the septum. This patient survived. There are case reports of fatalities, and so serial imaging was done, and eventually the hematoma will resolve as long as you can get them through supportive management during this period. Here's the algorithm that's been published here in the US, and you can look at that in your own time. Certainly this is not gospel truth. The Japanese have a different variant. I think most people who do significant volume don't follow it religiously, but we use this as a broad outline. If all three of these criteria are present, then you can do an antegrade approach. I'm sorry, if it's all present, then you do down the retrograde arm, so ambiguous cap, poor distal target, appropriate collaterals, retrograde. Otherwise, antegrade is preferred always. And what is our current map of how we're doing CTOs? Majority of them are being done antegrade, okay, either with wire escalation or dissection reentry. Only around 30% or so are being done retrograde. This is data from OpenCTO, and this is data which is almost identical from Progress CTO that was just published this year. Identical. So yes, retrograde is important, 1/3 of cases, but 2/3 are antegrade. Thank you very much.